Good morning. I'm Pat Croce, and this is the American Cancer Society's Healed Community Gathering. I want to start off by thanking our presenting sponsor, 6ABC, our leadership partners, all of them, who've helped us raise almost $2 million for the research that's being conducted in Atlanta at the American Cancer Society's headquarters right now as we speak on this healed research. And for each and every one of you who've gone onto our website, acshealed.com, and made a donation, any kind of donation, and have received your bracelet and are wearing it proudly. Again, this green bead signifies we're in this all together. Pass the word, share the movement. I start each of our gatherings with a moment of stillness to allow the past to be the past and to bring all of our attention lovingly into the present moment. And I'm at Meditation Hill right now, my place up in Bucks County, so I have my true Tibetan bell here. So close your eyes, if you will, and just listen to this. All of our attention for the next hour is on the present moment, and we have quite a show for you today. And I thank all of you for coming on, whether you're watching us live on Facebook or YouTube or recording. Our goal, our intention is to touch all of you who have been touched by cancer or who have been touched by someone who's been touched by cancer, to help you live more active, healthy, enjoyable lives in the present moment. Body, mind, and spirit. That's what our intention is, to bring it all together, to encourage you, to inform you, to inspire you, to entertain you, to allow you to be everything that you can possibly be. And we do this by bringing on several guests each week, and we've had such great guests. This is our 15th week so far, and you can see all the recordings. You can either go to acshealed.com or I think on 6abc.com. They have all their streaming, all the videos in their library. Our first guest today is a Dr. Shannon Lynch. And being from Philadelphia, we have some homies here today, two great homies. Dr. Shannon Lynch is an assistant professor in the Cancer Prevention and Control Program at Fox Chase Cancer Center. This is our first expert guest from Fox Chase. Dr. Lynch considers herself, check this out, a neighborhood researcher. So we're going to have to start by asking her what that is. And about 3 years ago, Dr. Lynch received a grant from the American Cancer Society to support her efforts to reduce racial disparities in prostate cancer. So I have all kinds of questions. I have a lot of friends, too many friends, who have been diagnosed with prostate cancer. And I love the researchers who are working in that field. Dr. Lynch, are you there?
I'm here. Thanks for having me, Pat.
Oh, my pleasure, Dr. Lynch. And first and foremost, and for all of us who are attending, Dr. Lynch said I could call her Shannon.
That's right.
Or Dr. Shannon, whatever. You got to tell me, what exactly is a neighborhood researcher? Sounds like you're a neighborhood grocer, but a neighborhood researcher.
Yeah, it's kind of a cute term that I came up with because in my work, I'm really interested in studying health disparities. So not just racial disparities or differences in cancer outcomes by race, ethnicity, but what factors could be contributing to those differences. And one of those factors is the neighborhood in which you live. So in my work, I use existing resources that we have, like the Pennsylvania State Cancer Registry, for example, and I use that information to identify neighborhoods where there's a higher burden of cancer. So where rates of advanced prostate cancer are higher than anticipated compared to the state, for example. And then I see if we can use that information to better target interventions to communities related to screening or knowledge and awareness. And then also utilize that information in a patient setting. Do patients want to know this information? Would it help them make better decisions to know that they live in a neighborhood where the cancer burden is higher than anticipated? So when I say neighborhood research, I mean, incorporating the environment where you live in your potential clinical decision making, and also for making smarter decisions about where to put screening and related interventions.
Okay, I want to hear all about your research, but first I want to hear more about you.
Sure.
How did you end up at Fox Chase? And then I want to know, how did you highlight this passion of yours to go into the neighborhood to find out about disparities and cancer intervention?
Sure. So I should first start by saying I am actually from Fox Chase. So I grew up in Northeast Philly, in Fox Chase. When I was in high school, I volunteered at Fox Chase Cancer Center. And while I was there, I helped organize patient charts. I would sneak in the patient rooms and I would talk to them. And that was one of my favorite experiences I had. So I'm from Fox Chase. So that's another reason why I call myself the neighborhood researcher. As far as, how I got interested in cancer research. So I come from a large family, like where I come from in my family very much influences my career path. So I have like 29 first cousins, then we're all really close. And we all live in the Philly area. And the one disease that has impacted my family the most and that I heard about first growing up was cancer. So all four of my grandparents had cancer. My grandfather lived for a while with prostate cancer. One of my favorite uncles, and I like to joke my favorite father-in-law because he's my only father-in-law, were recently diagnosed with prostate cancer. So the impact that this disease has on my family, that it has on the community, that I've seen it have on patients through my volunteer experiences that stemmed all the way back to high school, has really influenced my career path to focus on, fighting cancer, like mostly cancer prevention and early detection of cancer.
So when you went to Fox Chase, did you request your specialty, or did they channel you into what they thought you would be best suited for?
So typically the way it works is you define your own career path. So I had this background more so in molecular biology, genetics, like how genetics in your biology can influence cancer. And there are these methods involved in genetics and biology that allow you to look at a lot of genes or a lot of biomarkers and how it could relate to cancer. So what I did is I applied those methods to social data, to neighborhood data, to see if we can identify socioeconomic circumstances that might influence cancer outcomes in Black and white patients separately. So that was part of my dissertation work. So utilizing this social data and applying methods from biology to the social data so that we can better identify communities and patients who are at high risk for cancer. So I came to Fox Chase, talked to them about my research, and they were interested in hiring me based on my interests, because one of the priorities of, Fox Chase is a comprehensive cancer center. One of the priorities of a cancer center is to address disparities in what we call our catchment area, or where our patients come from. And, especially in prostate cancer, disparities play a huge role in the cancer burden there. There are race ethnic differences in prostate cancer mortality rates. Black men are more likely to be diagnosed with prostate cancer and twice as likely to die of it compared to white men. So it's important, in order for us to address the burden, for us to, conduct this type of research.
Would you say those again, those stats? You said them so fluently. I want to get those again.
Sure. So in prostate cancer, Black men are more likely to be diagnosed with prostate cancer and twice as likely to die of prostate cancer compared to white men. And this is a disparity that's existed for decades.
And from this data that's already out there, is this what you're using as health disparities that's focusing your research on the intervention?
So since we know these racial disparities exist, it's important to not just look at the racial disparities and identify them, but it's what can we do about it? To know what to do about it, we have to look at two other main factors, one of which is socioeconomic circumstances. So how does a person's income, education, employment, poverty level, how could that contribute to racial disparities? And then also the neighborhood in which a person lives, how can that, in the social circumstances of that neighborhood, the physical environment, like housing quality, all those factors work together to influence racial disparities. And if you really want to address prostate cancer disparities, you have to look at all three factors: differences by race, socioeconomic status, and the neighborhood in which a person lives, to better understand not only what patient population, so is it Black men with a certain socioeconomic status from a certain neighborhood that are at the highest risk, and should we target them to make sure that they're getting the screening interventions that they need, identifying patterns in the data to make sure that people who need resources are getting it the most. And also utilizing this data to go out into communities and talk about prostate cancer, increase awareness of prostate cancer, and potentially do screening related interventions in neighborhoods where there are higher mortality rates than anticipated, because we often have very limited resources for cancer prevention efforts.
Shannon, can you please tell me, this is interesting. Socioeconomic and males, Black males, but this whole neighborhood concept, like this is new to me. So how did you layer in the neighborhood with your research that was different from others?
So a field, it's called geospatial analysis. So that field has advanced so that, a lot of times we can look at cancer rates in Philadelphia overall. So the prostate cancer mortality rate in Philadelphia is about 29 per 100,000 people in the population, for example.
And where is that in a scale?
So Philadelphia's rates are higher than, prostate cancer mortality rates are higher than the state of Pennsylvania.
Oh.
And then as part of my American Cancer Society funded grant project, I was able to identify a small cluster of neighborhoods, which we define in terms of census tracts, which are smaller than zip codes. So a cluster of census tracts. Census tracts are smaller than zip codes. Census tracts have about 20,000 people in them. Census tracts have about 5,000 people in them. So the smaller the geography, the better, because we can better pinpoint what neighborhoods to target at that level. So I've identified a cluster of census tracts in the Philadelphia area where the rates of advanced prostate cancer are higher compared to the state by about 20%. So using that information, we can go back into those areas and identify men in those areas to see, what are potential barriers to screening, what do they know about prostate cancer, to then identify what interventions we can put into those communities.
Okay, so wait, this is good. So you got this magnifying glass and you took it from the state and you bring it down to the county, to the community, to the neighborhood, and then to this, what you're calling a census tract. And it's kind of like a family of people in this little area. And then from there, when you find these disparities and you find these diagnoses overwhelmingly higher, 20%, whatever it is, what do we do about it?
Exactly. So first, we tried to understand why there is that cluster. So
can you find out that? Can you find out why?
You can. So what I do is I utilize existing U.S. Census data, and I combine that with the registry data, which helps me identify those clusters. And what I found is that when you add them to a math model, if you add factors like whether a patient has insurance, for example, what their patient's race, ethnicity is, whether they live in an area of higher levels of poverty, what we found in this study is that the cluster in Philadelphia would just disappear. So that means if we're able to somehow address or identify patients who don't have insurance, who live in higher poverty areas, and get them the resource and equal access to quality care, we could eliminate that cluster in Philadelphia.
Wow.
So the problem is that these social determinants of health, these socioeconomic factors, they're a problem not just in prostate cancer and not just in cancer more broadly, but across other diseases. We see the parallels with COVID-19 as well, that people based on their social circumstances are having poor health outcomes. So that's why I'm doing this type of research, to not just identify where the burden is, but what factors could be contributing to the burden. And does that help us not just determine where to put the intervention, but what type of interventions might be most appropriate for that community?
So 2018 is when your research was first funded. How is the research going and what progress have you made?
Right. So we're at the stage where we've identified clusters. I've also incorporated the cluster information with medical record data. So
Are you allowed to get medical record
yes,
data?
Yes, we have what's called an institutional review board, where we talk about our study, and if we're using identifying information for patients, it goes through an institutional review board to make sure that we're adequately protecting human subjects. So we have approval to link patients to the neighborhood in which they live. So I'm looking to see if adding this cluster data and this socioeconomic data about a neighborhood to a patient's information, like what is their prostate PSA or prostate specific antigen level at the time of diagnosis, what's their race, ethnicity, do they have insurance or not? If we put that all in a model, does that better predict who's more likely to be diagnosed with advanced stage prostate cancer? And the goal here is twofold. One, to see if we can identify a pattern of risk factors in men that put people at risk for poor outcomes because of their social circumstances, but also to help men make better decisions. So do men and do clinicians want to know if men come from areas where there are higher rates of prostate cancer? Would that help them influence or decide whether to undergo PSA testing or prostate cancer screening? Would that help them decide what type of treatment to go with, to be more aggressive versus not? So those are things that we're investigating.
Wow, that's amazing. Is your research available to be disseminated as we speak?
So right now, the studies I talked about are unpublished, but what is available is a study that I worked on collaboratively with the Drexel University Urban Health Collaborative. So they were the lead on the project, together with Drexel, Fox Chase, and the Philadelphia Department of Public Health. We have an app online that's available. Yes, that allows you to look at cancer rates by neighborhood in Philadelphia. So you can compare mortality rates by Philadelphia neighborhoods. So for example,
What's the app called?
I can send you the link. It's called Cancer in Philadelphia Neighborhoods. If you Google it, you can.
I want Scotty to put it up on the tagline. So.
Okay, I will. What I can do is I can, when we take a break,
when we sit you on the bench.
When I'm on the bench, I'll be happy to send that around. But basically what it's shown is we grouped those census tracts into bigger neighborhoods, and we compared them to the city of Philadelphia, and we identified neighborhoods where the rates of prostate cancer mortality are higher compared to the rest of the city. So that would signify that in those neighborhoods, maybe we should target them more for interventions. So for example, the Nicetown Tioga neighborhood is the neighborhood that had the highest mortality rate of prostate cancer in the city of Philadelphia. But there were 8 out of 46 neighborhoods where the rates of prostate cancer death were higher than the rest of the city.
Wow. What are we doing about intervention based on your data?
So I can tell you what I'm doing now. So what I'm doing is going out into neighborhoods where we found a high risk cluster versus low risk, and recruiting men to see what the differences in those neighborhoods are. So in neighborhoods where the rates are lower, can we learn something about what they're doing or what their knowledge base is about prostate cancer to inform interventions in neighborhoods that have of men who are in neighborhoods in a high risk cluster. And then also talking to men from neighborhoods in a high risk cluster to see what their potential barriers are, so we can make more targeted interventions that will have a bigger impact on those communities that are most in need.
Okay, Dr. Lynch, what would you see as the number one barrier to date?
The number one barrier? I'd say, based on my research and the literature, that insurance status and equal access to care for all is the biggest barrier in prostate cancer. So not just in my study, but in national studies, it shows that, if men, regardless of race or backgrounds, are able to get equal access to care, and they tested this in the context of a veterans affairs setting, that the prostate cancer racial disparities could go away. So it's really just working together as communities to address some of these more systemic issues that we have with the social determinants of health, and making sure that people are not having poor outcomes just because of their social circumstances.
How receptive are the neighborhoods for you or to you when you come in?
So that's something I'm starting to explore now. One of my goals is to work with existing community partners in those neighborhoods. So to identify community partners in those high-risk neighborhoods, to get their input on how we go about reaching out to men in the neighborhoods and getting this message out about, prostate cancer awareness. So that's kind of the stage I'm at now. So we identified the high-risk clusters. We want to recruit men through our community partners that we have in those areas. The Fox Chase has an Office of Community Outreach that I'm working with. I also have some colleagues who mentioned that there's a mayor's council that we could contact and see if they have community partners that they think would be willing to work with us on this project. So it's really working with existing community partners to get the word out.
Shannon, do you have an end game to your research?
An end game? Oh, I'd like to eliminate health disparities. Of course, but it's something that I think requires efforts across not just cancer, but other disease sites. It requires policy and investment in public health in general. So, what I try to do in my research is not just, a lot of times people just look at, here's the geospatial analysis and that's it. I actually try to translate what I find to the next step and try to connect the dots.
Well, that's that basketball prowess in you.
Yeah.
So we were talking offline, and Dr. Lynch was a basketball player in D3 league, and she was a shooter and so I thought, wow, this is great. Now we're going to put you on the bench, but it's great to see that you can distribute the ball.
That's
and
right.
You know how to play with a team.
It's a team effort for sure.
Totally is. Now I'm going to bring you back. So you're not used to sitting on the bench, but you're going to have to just sit there for a little while longer.
Okay.
While we have Michael Nutter coming in.
Sounds good.
Thanks, Shannon. That's great. Unbelievable. Right now, our next guest is Michael Nutter. I haven't seen Michael in quite a while. The former mayor of Philadelphia for 8 years. He's a lifelong Philadelphian. One of those people, if you thought of a lifelong Philadelphian, you would think of Michael Nutter. Born and raised in West Philly and educated at Wharton School at the University of Pennsylvania. He's been dedicated to public life his entire life. And I want to hear the story and journey of his, speaking of prostate cancer, Michael has come out publicly just in the spring, early summer. I read a great article in the Inquirer about him. And so, Michael, are you there?
I am, Pat. How are you?
I'm great. Great
good to see you,
Mr. Mayor. It's been quite a while.
It has been a little while, but you are your usual irascible self. Nothing much has changed. I think you have more hair. I have less hair. I think that's the extent of it.
Yeah, but mine's gray. So, yeah. Michael, I read this great article as I was telling the gathering, and thank you for coming on. It's been our 15th.
Thanks for what you're doing.
Oh, no, it's just wonderful. Those of us who've been diagnosed with cancer, it doesn't affect us as the I that I am, but bodies, we made it a calling, right? And that's something that you've done. And this article was great, but I have to ask, give us how you were diagnosed, because that, I think, to me is the most crucial factor here.
Yeah. Well, first, and I know you quote unquote have her on the bench, but she's clearly ready to come in at any moment. I want to thank Dr. Lynch. She laid out the case, and I would love, quite frankly, to work with her. This geospatial kind of work, that kind of research, pinpointing where the trouble spots are and getting right into the community. That is the key. And, again, it bears repeating. Upwards of Black men have a 75% greater chance of having prostate cancer, twice as likely to die. But I'll give you one other interesting stat that I read somewhere. Early diagnosis and proper treatment, Black men actually have a greater survival rate
Oh, say that
than
again.
others. Early detection, early screening, and proper treatment, over time, Black men actually have a greater survival rate. And so this is not a situation where, I mean, look, at the end of the day, I mean, we all are going to die, right? But for me, at least in the decision that I made and the great care that I received, it will not be because of prostate cancer. And there are too many men in general, and Black men in particular, who die from prostate cancer unnecessarily because of many of the things that Dr. Lynch talked about. I had excellent care. I've been paying attention, in my 50s. Dr. Larry Belkoff and his great team at Mid-Atlantic Urology, while I was in office, after being out of office, just really paid attention and educated me about what was going on and had me pay more attention to my health. And yes, because of my service in government, out of government, I've had access to good health care. I've had access to great doctors. But at the end of the day, Pat, I got to tell you, no matter what you've done, no matter where you've been, things that you've maybe been able to achieve in life, whatever they are, when you have that conversation and when I was under active surveillance, which is one of the strategies dealing with prostate cancer. So you know that something's going on, but it's not perilous. It's not life-threatening. But I could see over time, especially when I left office, my PSA was going up. Not in a danger zone, but we were monitoring.
Michael, let's stop there for 1 second. How often did you have your PSA checked?
When I was in office, every year or every 18 months or so. I mean, I kind of got on a regular schedule of, my general physician or general practitioner, urologist, dentist, eye care, et cetera, et cetera. I mean, the summertime, things slow down a little bit. So I just kind of got into a rhythm of mostly going to any of the various doctors that I would see pretty much all around the same time. Sometimes, maybe I missed that summer and do it in the fall, whatever the case may be, but it was regular and we were paying attention. The fact of the matter, Pat, again, is, some people may not have the kind of healthcare that allows them to do that. They may have a job that doesn't allow them to pay as much attention as they should. Life intervenes, things go on, circumstances at home, whatever the case may be. So I know, that I was a beneficiary of these systems and the different positions that I've held. There's no question about that. And everyone doesn't have that in the first place. Again, Dr. Lynch talked about lack of access to healthcare, or, maybe you can't get as many checkups as I was fortunate enough to have. And so as I transitioned out of office, 15 into 16, and I was, really busy and now trying to figure out a post-mayoral life and out here, kind of hustling and grinding. Somewhere in the 16, 17 time period, I said, I probably need to get back to the doctor. I knew that, we were, paying attention. And then that particular PSA, so somewhere in the 2016, 2017 time period, did show upward movement. Again, not life-threatening, but it was starting to move up. But we were still doing active surveillance.
Michael, we should tell everyone right now that it's not exactly the number, but movement is the key.
Movement, yes.
The delta.
Yeah. So generally, and, we have Dr. Lynch, so, I could be wrong on any of this, but generally 0 to 4, on your PSA number, I mean, you're kind of in a fairly safe place. And I was there for a good while. The movement gave Dr. Belkoff and I some concern, but it was okay. Last year, in 2020, a couple things happened. First, this was in September of 2020. One day I was kind of not feeling well, felt a little warm, had a little bit of pain, And Lisa and I have been very, very focused on, COVID-19. She has type 2 diabetes. We've been very, and I'm just old. So we've been paying attention, to what was going on. This is, we didn't have a vaccine, all of that stuff, right? So she caught me, literally laying in bed one afternoon, like 1:00 in the afternoon. I was between Zoom calls. And she said, "What are you doing? What's going on?" I mean, it's like 1:00 in the afternoon. And I said, "Well, not feeling all that well. And I got a little bit of pain." She said, "Do you have a temperature?" I said, "Well, let me check." So it sounded like a couple of the conditions possibly related to COVID. So she said, "You need to go get a COVID test." So I go down to emergency room at HUP. I talked to Don Schwartz, who was my former health commissioner, deputy mayor for health and opportunity. I talked to my own doctor. Go to HUP, tell them your symptoms, and get a COVID test. I do that. I check in. My temperature is higher than it was when I was at home. My blood pressure's up. My pulse rate is up. Still got the pain, and I'm really feeling kind of lethargic. So, like, all the signs, right? They do the COVID test. Test is negative. I said, "Okay, great. I don't have COVID." They said, "Well, but you got all this other stuff, so we need to figure out what's going on." Long story short, CAT scan shows that my appendix had burst. Okay, 6 hours later, 7 hours later, I'm on the table, emergency appendectomy. And while I'm laying there in the hospital, because, you got to stay overnight, in my mind, I'm like, still got this other thing, and we've been monitoring my PSA. I need to get back to Dr. Belkoff. Take another PSA, I think sometime in October. Now my number is significantly up. And I didn't.
So wait, stop there. Stop. So in post appendectomy, you have this aha moment.
Well, I was laying in the hospital bed. I hadn't been in the hospital since I was 17 years old. A lot of things start going through your mind. I'm 60, 64, 63, 64.
But this is important, Michael. Right now, This is important that you made a totally life-changing situation at this moment. So take us through that.
I laying there, just thinking about stuff, like I had time. And I'm saying, I got to get back to the doc. I haven't been there in a while, and here's the thing. It's not like the number's suddenly going to go down. It doesn't go away, right? So I've come to the conclusion, you either deal with prostate cancer or it will deal with you, one way or the other. And so I just said, I need to get back, and I think I'm probably going to have to do something. So look, you've got active surveillance, radiology, and surgery. I mean, they're the three primary ways to deal with this. And once I got my next PSA, active surveillance was really kind of off the table. So now you're down to the other two. Each has their pluses, each has their minuses. I'm not here to tell people what to do. I made a choice based on, my life and how I wanted to, kind of go forward. And it's American Cancer Society, and we're having this kind of conversation. So, what are the issues with surgery? Primarily, there are three, as explained to me by Dr. Belkoff and Dr. McGinnis, my surgeon. A, does the surgery get all the cancer? B, issues of incontinence. C, sexual function, because they're operating all in the same area. You've got nerves and all of this, and they're fairly unprotected. Get jostled, might shut down, all kinds of things. So look, men. We think about all this stuff, right? And so much of our masculinity can be tied into, a number of issues and things that we think are important. Pat, I made the decision at the end of the day, this is about life and death. I'll try to deal with all those other things. I'm trying to live. And so when Dr. Belkoff said, look, here's your number. Active surveillance is no longer really an option. We now need to make a decision. This is like October, November of last year. He then introduced me to Dr. David McGinnis, one of his partners. We sat and we chatted. Very straightforward, very serious guy. I tried to get him to laugh a couple of times, maybe not that successful, but he's serious about his business, right? And I felt confident. And this is the other point. I had confidence in Dr. Belkoff. I had confidence in Dr. McGinnis. And they gave me the confidence and the strength to move forward. Now, I made one big mistake in all of this. That's your family. Again, as a guy, sometimes, we think we got to have it all wrapped tight with a bow. We got to have all the answers. We're insecure about some things. We don't want to talk about certain things. And I had not, up until this point, when I had not had the serious conversation with my family about what was going on. Didn't want to burden them. Daughter graduated from college, gone on with her career. Her wife is doing her work. That was a mistake. But finally, I sat down with the family and said, look, here's my test. This is what we need to do. I have a surgeon. I picked a date. I need your love and support, which was immediate. It was universal. And that family component, whatever your family is, whoever your family is, knowing that I had their support and their love and their care, that was a great part of my recovery. Had surgery December 9th. Stay overnight. You have a catheter. Come back in a week. Gets removed. Dr. McGinnis told me then the pathology showed that they got all the cancer. There was no spread.
Yes.
And he thought that I was going to have a full and complete recovery. 3 months later, in the protocol, you get your PSA, which is your baseline. My PSA was 0.
Oh, yes.
0.
Yes. How'd you feel about that?
Oh, that was a joyous day.
That's like an NBA championship right there.
It was the first time in my life that 0 was the best number I could get. 0.
You just won every championship right there.
Right there, right? And so for the next 2 years, get a PSA test every 6 months. Get ready to that's getting ready to come up end of this month. And I'll see him back in September. And then after 2 years, it's once a year. I told both of them, whatever I can do to talk to men, and especially Black men. I reached out to one of the reps at the American Cancer Society, which is how I ended up here with you today. You don't have to suffer in silence. You don't have to have a diminished quality of life. Every person is different. We got all basic same equipment, but it's like a car. Every car is different, but they all got an engine and transmission. But they're all constructed a little differently. But you got to know your number, and you got to get on it early and pay attention to what's going on with your body. Those aches and pains, like I said, I had a little ache in my side. I thought I had indigestion. Turns out my appendix had burst. Right?
You're a tough guy. You were always a tough guy.
We just need I'm. Some days I might be tough. I might not be the smartest, right? So we just need to pay attention to ourselves.
You talked about family, Michael. You talked about family. So I just want to go back to that. Was it 4 years that you carried the elevated PSA without telling Lisa and the family?
A little over 3.
And how did you feel any subtle unease about that the entire time?
Of course. And in my mind, because, again, I can say as men, we have an enormous ability to ignore, things that are really important to our own health and challenges, because I'm always thinking, let me just deal with this. This is my issue. This is my problem. I don't need to burden them with worrying about, what am I doing or what am I going to do? And the other part of that is I didn't have a plan yet. I didn't know what I was going to do, right? So, I'm a guy, I would tell my folks all the time, if there is a problem, come to me not only with the problem, but a solution. And I didn't yet have my solution. Mm. When I did, I just laid it all out. And I mean, they just could not have been more understanding, more support. I mean, they weren't thrilled with how I handled it. And, they both let me know in their own way. But then we got past that. And then it was, from getting to the hospital to coming home to the week in between and, dealing with, some of those challenges, a little bit of pain. But, the other thing I want to communicate, Pat, is people may have old stories about prostate cancer surgery, right? It's tremendously invasive, open you up and all that. Man, we're in the robotic world now. We're doing laparoscopic surgery with a couple incisions, which heal pretty quickly. It's significant surgery. There's no question about it. But I mean, this is not like back in our grandpop days, right? This is the height of science and technology, and it's about living, and it's about quality of life for going forward. So I am. I'm enthusiastic about being with you. I'm enthusiastic about the American Cancer Society and the work they're doing. I'm enthusiastic about what Dr. Lynch has laid out, and I just want to communicate that message to these men. Do not ignore it. It's not going away on its own, but you don't have to suffer unnecessarily. But know your number, and then take action.
I saw you had those two big words in that article, that Inquirer article: get screened.
Get screened. Get screened. I mean, when it's a blood test, right? I mean, obviously with urologists, I mean, there's the PSA exam and the digital exam, and okay, fine. You deal with that. It's pretty quick, right? The blood work is your normal blood work. I mean, they just draw blood, check a box on your lab form. It's just one more test, right? There's nothing extra. Right. But to have that knowledge, to be able to take, control a little more of your life is so important.
Michael, I think it's beautiful what you're doing. My father died of prostate cancer and metastasized to his bones. So I had always asked, he didn't have a PSA. Yeah. I always asked once I realized that 93, I want, a PSA. Always give me a PSA. I didn't even know what a PSA was, but at that time, but give me a PSA because I heard that can help prevent.
Absolutely.
With early detection.
Yeah. Well, you knowledge and information, data, right? Just literally, the doctor just has to check one more box on that
on the blood work
form, right? You got 50 boxes on there, right? Just check one more, right? And know your number. And if there's nothing going on, fine. Then just pay attention to it. If there is something going on, don't delay. It's not going down on its own. You have to do something, but get screened early on, early detection, and then you make your own decision from there.
Now, is there a risk to screening?
Well, again, I'm not a doctor, but no, I don't think so. I mean,
no, I want you to say that's important. No, that's really important.
I mean, it's the difference between knowing and not knowing. The risk is not being screened. That's the risk. The risk is not knowing what your situation is.
So you're a father. You're my father to many people. Right now, if my father didn't die of it, I would not have known. Who would have told me? You are telling literally tens of thousands of people to get screened. There's no risk in screening. It's just blood work.
Just blood work like you would normally do for anything else. Right?
Well, last question before I bring Dr. Lynch back on, and then we can have a full discussion between the both of you.
Yeah.
How are you doing right now?
I'm fantastic. Look, the challenge and tragedy of COVID-19, the racial reckoning issues that we've been dealing with, devastation of, city budgets. I still pay attention, obviously, to these things that in Philly and a number of other places, levels of violence and the learning loss for our children. But look, I wear my mask. I wash my hands. I got vaccinated. I still do social distancing and just modify, certainly some of the things that I do. But from a health standpoint, doing great, having a good time, working, mostly on the, as they say, on the Zoom machine. No, I'm feeling good. And I'm just glad, I was afraid, Pat. I was afraid.
Mm-hmm. Good. I'm glad you admit that.
I was afraid. When I was going to say earlier, when you have that conversation with your doctor and they tell you you have cancer, it's frightening. But then it's like, okay, but now what? What are my options? What am I going to do? I want to be here. I want to live, right? So lay out, what my options are. And then you just, you got, as we say in Philly, you got to put your big boy pants on and make some decisions. I'm glad I did. And the last thing I'll say on this is it was nowhere near what I thought it was going to be. It was nowhere near. It was not bad. It was not horrible. It was not some devastating, kind of thing. And part of the reason is because we got on it early. Right? So everybody's got to make their own decision. Talk to your doctor, talk to your family, do it early, find out what's going on, and then go on and continue to live your life. I've got stuff I still need to do, stuff I want to do, and like I said, our day will come for each one of us. But prostate cancer is not taking me out of here. They got to find something else to come get me, because it ain't going to be that.
Great line. Great line. Stay right there, Michael.
All right.
Dr. Shannon Lynch, come on back on, doctor.
Hello.
Hey, Dr. Lynch.
Hi. Nice
Well,
to see
you two
Thank
are
you
a
for your
1-2 punch.
Thank you so much for what you're doing. Thank you for your work, and anything I can do to be helpful to you, please don't hesitate.
Thank you. Yeah, I think it would be great, like you mentioned, if we could work together and combine, some of the findings that we've been seeing with your interest now in advocacy and bringing awareness to prostate cancer. I think it would be a seamless collaboration. So I'm happy to do that.
I'd love to.
Yeah.
It's funny the magical ways God works, isn't it?
Mm-hmm.
Every day.
Diana, come on, because I know Diana has questions for you.
Wow. Okay.
Hi, Pat. Yes, we do have a couple of questions.
Mm-hmm.
Dr. Lynch, the first one is for you. What is the current recommendation for when men should start getting screened for prostate cancer? And as Mayor Nutter said, there's several different options for that. What is the current guidelines?
Right. I'm so glad you brought that up, because that was one of the first things I thought we should discuss, given the conversation that Pat and Mayor Nutter had. So the American Cancer Society guidelines for men for prostate cancer screening involved what's called informed decision-making or shared decision-making with a patient and their clinician, based on and where they decide whether the man should undergo PSA testing or not just based on medical factors like what happens if your PSA is high or low, how often do we screen, but also on the patient preferences. Because as Mayor Nutter mentioned, you could get screened for prostate cancer. We talked about statistics where prostate cancer has a high survival rate. Most men who are diagnosed with prostate cancer have low stage disease, but they can undergo treatments that could potentially affect their quality of life. So that's why the recommendation isn't just get the blood test or not. It's talk to your doctor first, engage in this shared decision-making on whether PSA testing is right for you. So you engage in this process at specific ages. So the American Cancer Society says you should engage in shared decision-making to undergo a PSA test or not at age 50 if you're at average risk for prostate cancer. At age 45, if you're at higher risk than average for prostate cancer. So you're at higher risk than average if you are a Black man, or if you have a prostate cancer family history of a first-degree relative. So a father or a brother has prostate cancer. So Pat, it's probably good that you talked about PSA.
And I think I was about 40 at that time when I got it first checked.
Right. And, my husband now is in that high-risk group too. So he would have to start talking with his doctor at age 45. And then they actually suggest that you start talking to your doctor about PSA testing at age 40 if you're at an extreme high risk, which means you have more than 2 relatives who've been diagnosed with prostate cancer. So if you have a father and a brother, for example, who have been diagnosed with prostate cancer, your risk is much higher. So, my dad falls into that category. His dad and his brother both have prostate cancer. So that's something that we, want to make sure that moving forward, you talk to your doctor if you're in that high risk group.
Can we stay there just for a second, Dr. Lynch, because based on those risk factors that you just talked about, how about applying your research to those testings? How about the neighborhood now? Some of these other things that you've been talking about seems like red flags that might be brought up that you might want to get tested because of this neighborhood.
Well, that's something we're interested in studying a little bit more. The recommendation is to base it on an individual risk, not necessarily your neighborhood risk at this time, like whether you live in a neighborhood of higher than expected rates. But that's something we're exploring. I think what we can do is in the neighborhood studies, we've identified where men are dying of prostate cancer and where the rates of advanced prostate cancer are higher than anticipated. So that would suggest screening or awareness of what the screening recommendations are. Do men know what the screening recommendations are in those neighborhoods? Do they know that there's a burden? Do they want to know that there's a prostate cancer burden in their neighborhood? And collecting data about these issues will help us make smarter decisions about what type of interventions are most appropriate. Because right now, the recommendations we have for prostate cancer screening a lot of times are based on studies where there aren't a lot of minority men included in those studies, or even like very high risk individuals. So we're still even understanding if these are the proper recommendations for these high risk groups. So there's still a lot of work to be done.
That's why they pay you the big bucks.
Diana,
Go
I don't know
ahead.
about big bucks, but they for me, and American Cancer Society does for sure.
Dr. Lynch, just piggybacking on that a little bit. So for a person who might not have a primary care doctor who wants to talk about screening or feel they have a family history, what's your recommendation for someone who might live in a neighborhood that would be benefiting from your study, who hears about prostate cancer, has a family history, but doesn't have a primary doctor? What's your recommendation for someone in that situation to get screened?
Yeah, that's really tough. But in some of the neighborhoods where this is happening, a lot of times, up to 10% of the people in the neighborhood don't have health insurance, and that might be why they don't have a primary care doctor. There are federally qualified health centers where you can go and get this type of clinical care if you don't have a primary care doctor yourself. So that's one place that you can look towards the federally qualified health centers. Okay.
Right.
And Mayor Nutter, a question for you.
Yeah.
You talked about how men might have some feelings about, talking about their prostate cancer and getting screened and what it involves. What's your advice for someone who is at the age where they should start talking to their doctor about getting screened, who might be reluctant to do so?
I was wondering how you were going to tiptoe through that difficult part there. I go back to something that Dr. Lynch touched on, but I'd like to kind of lift up a little bit more. Part of this really is about information and education. Mm-hmm. As I say, it's hard to know what you don't know. And so I think we also need to almost really kind of flood many of these communities and neighborhoods just with the information. And to be blunt, probably getting it not just to men.
Yep.
Other family members.
Mm-hmm.
Girlfriend, spouse, mom, grandmom, kids, whatever the case may be. And, they can have an influence on the, recalcitrant guy to, do what needs to be done. So I think that's first. Second, this is not like, oh, my shoulder was hurting, and so let me take an aspirin or ibuprofen or something, and it'll be better tomorrow. It's not like that. But the other important part here is, as Pat asked me, even with active surveillance, I mean, unlike a lot of other diseases, there's no outward sign in particular. I mean, if your prostate is getting bigger, it creates more pressure. Maybe you're going to the bathroom more. You can convince yourself that, well, I'm just getting old. And that's kind of what happens. So there are a lot of ways to literally just ignore what's going on. And I think, again, with education and information, access to the federally qualified health centers or city health center or whatever the case may be, just pay attention to you cannot ignore this particular issue. There will be no outward sign. It's not like a broken arm. It's right. You'll go about your normal day-to-day. You're going to your gig. You're doing your thing. You're hanging out with your family. In the meantime, this thing is happening within you. And so, the problem here is, if you wait too long, you're literally reducing all of your good options for really treating this. The longer it goes on, the window of your options is closing on you, and then you're confronted with it at the end, and it literally could be too late. So you got to deal with it.
Wonderful.
Any more, Diana?
No, that's all the questions we have today, Pat. Thanks.
Okay.
Dr. Lynch, this may be off target, but I'm going to ask Michael a question. You just talked about one of the most memorable moments you had post-mayorhood with that 0 PSA, that great feeling, that exuberant feeling. And I don't get a chance, Dr. Lynch, to talk to a former mayor of Philadelphia, my born and bred city I love.
Yeah.
This is such a setup question here.
No, yeah, it is, but it's easy.
I can feel it coming.
Easy. It should be easy because, I'm a positive guy, Michael.
I
You
know
know
that.
that. So you spent 8 years in City Hall. Do you have your most memorable moment?
Well, because I'm a recovering politician, I wouldn't be able to say one. But
Good.
I'll give you two. I'll give you 2 endpoints. Phillies won the World Series my first year in office.
Mhm.
I got to throw out the home opener pitch that year. It was a strike. And then in my last year in 2015, we welcomed Pope Francis and about 1 million of his friends to Philadelphia. That was in September of 2015. And I give those 2 as the beginning and the end. But Pat, as you well know, there was a whole lot of other things in between those 2 points. Tremendous number of highs, certainly some lows. But I love public service, and I'm grateful to the citizens of the city who gave me the opportunity to serve for so many years.
You touched a lot of Philly souls, Michael, and elsewhere.
Thank you.
Dr. Lynch, do you have anything else you would like to share with our gathering before we say goodnight?
I would just like to say thank you for your time to make sure that you're aware of what the cancer screening guidelines are, particularly since we're talking about prostate cancer today. We went over what they are. And I really like what Mayor Nutter said as far as, don't ignore the signs, don't ignore the symptoms, know what the screening guidelines are, and go see your doctor.
Michael, go ahead, wrap it up, Michael.
Get screened.
Mm-hmm.
Get screened.
2-word mantra, get screened. Well, thank you, Mayor Michael Nutter. Thank you, Dr. Shannon Lynch. Thank you very much for great information.
Thank you, Diana.
Thank
And
you.
I always end the gathering, I end our ACS Healed gathering with a prayer. And it's a very simple prayer. And it's a prayer of appreciation, of gratitude. Just thank you for the grace in helping me welcome what is happening right now. Because when we're in this cancer world, it's right now that's so important. And so the grace was necessary to welcome it and keep in the present moment and not mentally suffer, but handle your situation with grace. Thank you all. Thank you for coming.
Thank you.
Really appreciate it.
Thank you.
Peace.
Great to
Thanks
meet you.
for having me.
Bye-bye. Thanks.